Welcome to the Rational Egoist. I'm your host, Michael Liebowitz. In recent years, we've heard a lot in the news about the opioid epidemic. So I figured I'd get on a specialist who could talk about it. And that's what we're going to do today. Today's guest specializes in addiction psychiatry at Weill Cornell Medicine in New York. Jonathan Avery, welcome to the Rational Egoist.
Hey, thanks for having me. I'm happy to. I could talk about addiction all day, and it's an important topic, and it's who better to talk about it with than you. I appreciate you having me on.
Thank you. Well, both of my parents were heroin addicts. I've used heroin when I was younger. I don't know if I would be counted as an addict because it was a very brief period of my life, but I certainly ended up having to use methadone to get off of it. So I understand the seriousness of it. Now you focused on the stigma of addiction. So first of all, why is there stigmas surrounding addiction and why does it matter?
Yeah, I think I continue to be very discouraged by the incredible amount of negative attitudes towards substance use disorders and people struggling with them. And I think we've done a good job with so many other conditions over the years. Cancer used to be stigmatized, HIV, on down the line of medical conditions, but this is one that has always been viewed differently. And, my research has shown that our attitudes are worse towards people with substance use disorders than towards any other medical or psychiatric condition. And I focus primarily on lawyers and doctors and other healthcare providers and looked at their attitudes, which aren't different than the general population's attitudes. And so, it's a very pervasive problem. And it's important because these attitudes, I think, are a large part why no one gets treatment. Like less than 1 in 10 people seek treatment for their substance use disorder. There's still a view that it's shameful, that it's a moral failing, bad people doing bad things. And, I think a lot of what drives the stigma is sort of rejecting this notion that, people are really doing the best they can. They're often self-medicating with mental health stuff or trauma. When you use it, hijacks the reward pathway. And I know because I've had people in my family and in life, people with substance use are sometimes the best people in our lives, and we just put them down and push them to the shadows. And I think that's driving a lot of the opioid epidemic, and one of the reasons why it continues so unabated today.
So, how serious is the opioid epidemic? Because I know that the media can make things seem far more prevalent than they are. I remember, I think it was year 2000, and every night on the news, we were hearing about shark attacks. At the end of the whole thing, it turned out that that summer there was actually less shark attacks than there normally are. But yet, because the media focused on it, it just seemed like it was, happening every day. Is the opioid epidemic a serious thing or is it just media hype?
Well, you certainly can't count on the media for nuance. I think that's fair. It's a problem. I mean, the if in terms of like absolute numbers, the thing that's causing the most visits to our hospital remains alcohol. And we have like 9,000 presentations to our hospital a year for alcohol use disorder versus 1,000 for opioids. And alcohol probably kills more people than opiates each year, either from accidents or from the medical consequences of it. And so, it's definitely not quite right sized with a bunch of other addictions and the coverage that things get. But it's still a big problem. I mean, we're in what's called the third wave now, where it went from basically doctors overprescribing opiates to, heroin, people picking up heroin to now we're in what's called the fentanyl opiate epidemic, where basically fentanyl is being shipped into the country, pressed into a bunch of pills, and anything that doesn't come from a pharmacy carries the risk of fentanyl contamination. And the result of that is, despite a lot of efforts to combat it, we're still at about 100,000 deaths a year. In New York City, where I am, 5 to 10 deaths a day. And, we see quite a few people each and every day here at the hospital coming in with overdoses or near overdoses. And so it's still a problem and a big one, and has remained pretty constant, if not increasing, secondary to fentanyl and also COVID and all the stresses of the recent years.
I'm happy you mentioned overdoses because overdoses are a serious thing. I remember when I was using drugs, whether it was marijuana, heroin, whatever, and I'm going into back alleys to meet some guy I don't know, and he's selling me drugs. Now, I don't know what he's put in this drug. He doesn't know what his guy put in this drug. So there's really no way that you can know what you're getting. when I think about it, I mean, it just seems crazy to me, but people do crazy things. But wouldn't, if drugs were legal, right? If heroin was legal, wouldn't that cut down on overdoses because you would then know what was in the drug? So if, for instance, if I go to the pharmacy and I want to purchase heroin, right now, if I go purchase alcohol, I can see on the bottle, okay, 40% alcohol, 80 proof. I know exactly what I'm getting. If I get a medication from a pharmacy, it tells me the milligrams, I can find out the ingredients, everything. You don't have that in a black market. But if it were legal, you would then know what's in the product and how potent the product is. Wouldn't that cut down on overdoses?
It's one of the strongest arguments for legalizing or decriminalizing substances is that, yeah, a lot of our efforts at prohibition or incriminating substance use disorders has just led to more and more dangerous use. I think that's pretty clear that we've been unable to and not thoughtful about how we sort of regulate the drugs and how we prosecute people totally unfairly. And so yeah, I agree that a lot of the illicit stuff that has fentanyl in it could be corrected by a more regulated market. And, I think we're, doing better with the safe injection sites and, the fentanyl test strips where you can test your product and Narcan, and we're trying harm reduction efforts, but it doesn't go quite far enough because people are still dying and the product is still very potent and problematic, and so that is certainly one solution that I think could help. I agree.
And I also think it would show a respect for the freedom of choice that people ought to have in a supposedly free country, that we should be free to make our own decisions, to use what we want, to do what we want. And like you mentioned, people will say, well, it's so harmful, but alcohol, I remember when I was 16 years old and I was in a psychology class in school.
Yeah.
And they had a comparison of the various effects of different drugs. And I remember looking at alcohol and comparing it to virtually every other substance they listed. And alcohol was far worse in terms of the effects on the body, the long-term, addictions, the withdrawal effects. Everything was worse for alcohol, and yet alcohol is legal. And the funny thing is, when alcohol was prohibited, you had some of the same things. Impurities in the alcohol were causing people to get sick because it was being mixed with things and no one knew it was in it. And it just seems like we're in the 21st century now. Why haven't we learned this lesson to stop trying to regulate human choices when those choices are not violating anybody else's rights? Like, you're in the field. Are you seeing any headway made in attitudes about this?
No, not a lot.
Oh my
Not as much as you
God.
would hope. And that goes back to the stigma. I mean, attitudes are in my research and in other people's research, they're worse towards people that use drugs and alcohol. And you can't talk to anyone about what you just said, that alcohol is potentially more worse than to the body than so many other substances, that it's associated with all sorts of crime, domestic abuse, trauma, and we just choose it as our preferred substance because it has the stories we tell about it are different than the stories we tell about other substances. It all just ties back to fear and stigma, and so it doesn't make sense. Like, you can't look at the problem we're facing and our different attitudes, the different way we regulate drugs, and make it make sense, because it doesn't, and it's causing a lot of deaths.
What are fentanyl test strips? I had never heard of them until I read an interview with you maybe a week ago. I'd never heard of fentanyl test strips. And I was in prison 6 months ago in a drug program there, and they never mentioned them. What are they, and why aren't they more available?
They're historically, for a while now, Narcan, which is now in nasal spray form that you can give to someone if they overdose, it rescues a life. That had been sort of the main harm reduction thing that people had gotten government funding for and had been, given out a lot across the country. People tried for a number of years to give fentanyl test strips with the Narcan, but it was always thought to be it was a more stigmatized harm reduction effort. People didn't want to put funding towards it. They thought it would encourage drug use, and that sort of thing. Similar arguments to Narcan. Narcan's now over the counter. Biden and the government are finally funding fentanyl test strips, and so now they're sort of coming up and everywhere. And basically, it's a strip where you take a little bit of the product that you're using, put it in water, you dip the test stick, and it lets you know if fentanyl is present in your product, and that allows you to know. One of the reasons people overdose is they're used to using one product without fentanyl. They get a product that's contaminated, it's so much more powerful. And so, if you test it, hey, fentanyl's in there. Let me make sure if I do use it, I don't use alone. I have Narcan handy. Or let me switch dealers or find a better supply if it looks like this one's going to be contaminated. And so, people worry, hey, is this encouraging drug use? But it's pretty clear anywhere that you give out Narcan, give out fentanyl test strips, decreases overdose, increases access to treatment, improves people's lives. And so again, it's just fear, stigma about things people don't know. And the crazy thing is that no one's immune to addiction. Like it affects like 1/3 to 2/3 of us. Like if it's other until it's in your backyard and
No,
it's
it's
going to be
not.
there.
Yeah.
It's not there already.
Now, what is fentanyl?
So fentanyl it's a really power. So when we talk about the opiate epidemic, opiates are things like heroin, or you might think of prescription pain medications like oxycodone, Vicodin. Fentanyl's been around a long time. It's a very potent opiate that we use in anesthesia or in very severe pain states. It's been well known in hospital and anesthesia settings for a long time. What happened is that you can get very potent, cheap versions of it that are, for a very little bit of it, you can make a lot of product and a lot of potent product. And so people seeing the opiate epidemic in the United States thought it'd be a wise business plan to very cheaply send all this in, press it into a bunch of drugs. And so you can, create a lot of product that's potent very cheaply. And that led to it being sort of spreading around the country. It's just a very powerful opiate. And so basically, if you're looking for heroin on the street these days, Oxy, Percocet, even pills marked as Xanax or Adderall or cocaine, there's the risk that actually fentanyl now, or has some fentanyl in addition to the product that you're seeking. And that's sort of the scary nature of the opiate epidemic, where maybe half the people that overdose don't even realize they're using an opiate. They're trying to stay away from it, but they're getting some accidental exposure.
Now, is there any truth to the idea that, say I come across somebody and they've overdosed, if they have fentanyl on their person and I try to help them and I touch the fentanyl, is there any truth to the idea that it's going to affect me, or that I could die simply from being in proximity to it or touching it? Or would I actually have to ingest it?
You have to ingest it. I mean, it's one of the biggest myths, and it's been perpetuated by sort of a lot of viral videos of police officers, especially, seeming to have fentanyl exposure when encountering someone using substances. But I think in almost all cases, it's turned out they've had a panic attack or just very anxious in the setting and weren't actually exposed to fentanyl in that way. And there's a lot of prominent addiction folks that are debunking some of this
Good.
accidental exposure to fentanyl stuff and some of the viral videos that it's also, it goes back to the media. The media loves to pick up on this stuff, create fear, make it seem like, they love to any sort of viral exaggerated video pretty much turns out to be false as it relates to fentanyl exposure. So it's got to be ingested in pills, and it's not floating around
or
the
shot
air.
up or snorted something.
Exactly. But you're not going to be walking down the street and find yourself accidentally in a fentanyl overdose or shaking someone's hand or trying to rescue someone's life, for sure.
So I used to get really bad panic attacks that led to really bad anxiety. And I remember going to the psychiatric nurse in prison and trying to get treated for it. And she told me they were going to put me on, I think at the time it was Paxil, but I'm not positive. Anyway, it was something that was going to take weeks to work.
Right.
And I told her, well, why can't you give me something short range like an Ativan or Valium, Xanax, a small dose that will work immediately? And she said to me, well, that's just the addict in you talking. You want immediate gratification. And at the time, I thought that was a very salient point she made. But in retrospect, I don't think that you have to be an addict to want relief from suffering. And my point is this: if somebody is in really bad pain and they go to a doctor, and now there's sort of a stigma attached to prescribing painkillers on the part of doctors, No, I've done a lot of study in economics, which they show a lot of unintended consequences. So it seems to me that if somebody's going to a doctor and they want to get Oxycontin, for instance, or Percocet, but now the doctors are very hesitant to prescribe it, the person is still in pain, and some at least are still going to seek relief from that pain. Can't that have a tendency to push people to a black market to buy oxys or buy heroin, and then you increase the risk that they're going to come in contact with fentanyl?
There's so many great points on what you just said that I want to address. I think the reality is that we haven't been nuanced around the opiate epidemic. So, at first, 80s, 90s, pain was the fifth vital sign. You couldn't go wrong giving people opioids. So I broke my foot in the 90s. I got 180 Percocet, and I only needed one, but they were just giving people a ton of them, right? And that led to problems. And so, fast forward, too many prescription opiates, heroin, now it's the fentanyl opiate epidemic. Now everyone's super scared to prescribe opiates because of what they've heard coming to lectures from addiction providers, the media. Doctors aren't immune to any of it. And now we're seeing people inadequately treating pain, as you're describing, people that really need it. And we still think opiates help in the right setting. They help for severe acute pain. They help in cancer pain, end of life distress, other sort of chronic pain conditions that don't respond to other interventions. Like my dad's a hospice physician. I've done a lot of end of life work. And one consequence of the opiate epidemic is that people who are really suffering at the end of life with cancer and other things, they were refusing opiates because I don't want to be an addict. And that's like the perfect time where you need opiates. They're really going to help relieve distress, improve quality of life, and help with meaning. And so, yeah, we've swung the pendulum back and forth and overcorrected way too many times. And we may have overcorrected too much in the wrong direction. The other point you make, which is a key one, is that we can't not address co-occurring psychiatric disorders, mental health, medical issues because we're concerned about individual substance use disorder. Like we know, for example, if someone has ADHD and they've misused stimulants, still getting them on stimulants thoughtfully improve outcomes. Like, you can't not treat the thing that's important to that they're dealing with, because if you don't, then they're going to use other substances and be pushed into other things, as you've mentioned, right? If you don't provide some immediate relief for panic, that just encourages people to go and get it from the opposite direction. You have to do it thoughtfully. You have to pay attention to the substance use disorder, but we've learned over and over again that you can't just treat the addiction. You need to treat the co-occurring conditions. Otherwise, the addiction is just going to perpetuate, maybe in a different way because you're withholding something, but it will continue.
When it comes to the risks of being prescribed an opiate, or an opioid rather, when you go to a doctor, what are the actual chances? How high are they that people are going to become addicted? Like if I break my leg, I go to a doctor, he prescribes me oxys or perks. How high is the risk that I'm actually going to become addicted? Because I've heard it's very low, but I don't know for sure.
Yeah, no, it's very low. If you're treating acute pain states, even if you have a history of mental health issues or addiction, under treating the pain might be as risky for mental health and addiction as not. There are some things that increase your risk for being stuck on opiates if you're prescribed, and those are having a history of mental health and trauma and a history of addiction. Also, the longer you're on a prescription, the harder it is to get off of it. But again, there are risks for not treating, and
Sure.
and those might be greater, and they can include suicide and worsening of all of the above if you don't. And so I've seen so many, over the years now, not only end of life, but people coming in with like really bad injuries, just refusing opiates that we want to prescribe as doctors just because they're so concerned about it. And we're like, no, we'll monitor it, you need it. You can't have this degree of pain. You're not going to sleep. You're going to get terrible. If pain's going to get worse, it's going to worsen your physical condition. So, we've definitely got to avoid that overcorrection.
It seems like that's a big problem. I mean, I've seen it in other aspects of life too, but here we're only looking at one side of the ledger. What I mean is that somebody comes in, they're in pain, and you say, not you, but the doctor, well, I can't prescribe opiates because the chances are too high for addiction. But there's risks, like you said, on the other side of it too. there's the risk that the person's going to go get it on his own. There's the risk of suicide, risk of mental health problems. All types of things can happen when a person's on pain. And similar with legalization of drugs, they say, oh, but more people are going to use, you're going to have overdoses, but they ignore the risks that are happening now, the overdoses that are taking place because of impurities in the drug, the gang violence over drug wars. That's a part of it too. And we have to look at everything when making these types of decisions. As a psychiatrist, do you see that problem amongst your peers where they have that problem of only looking at one side of the equation and not taking all factors into consideration?
For sure. And the funny thing about it is that our current approach hasn't helped. It's not like we've taken one side of the ledger. We've, punished people, kicked them out of schools, imprisoned them. We've not prescribed them medications. I mean, right now we've done all these efforts to curb opioid prescribing, to curb benzo prescribing, and it hasn't made a dent on the opioid epidemic. In fact, it's worse than ever. So we've tried to imprison people, we've tried to withhold substances, we've tried to, label people, as addicts and distance ourselves from them, and none of it's helped. And it's made everything worse. And so, yeah, we need different approaches that pay attention to the whole person, that treat people with kindness, that get them the assistance they need. And we've got to get out of this mindset that we can, punish, shame, label it out of people, because that's not going to help. And then once you find yourself, I mean, there is a point, and I see that it's for so many people, even doctors, because doctors are more at risk for addiction than others, where suddenly it happens to you, right? And you're like, oh shit, I have totally I missed it. I didn't see it. That this is everyone, that this is something that can happen to all of us. And I've been very narrow-minded. And so, if you think one way, eventually life will correct you, but it's so hard to make that societal change. Like, so many people have tried and tried nobly, and if we haven't quite gotten it yet. I mean, there's small gains here and there, Narcan over the counter, but it's not big gains.
And that's what we need. We need big gains. So are there effective treatments for opiate use, for heroin, oxys, whatever? Are there effective treatments? And if so, what are they?
Yeah, so the tricky for most substances that people get in trouble, the reality is that they're mostly self-limiting. People often are able to stop and get off it on their own. And a lot of the treatments that exist are.
Can you hold on for 1 second?
Yeah.
Because that's very important, what you just said. You said people a lot are able to get off it on their own. The reason it's important to me is because in 25 years of incarceration, through basically you have to do it, although it's not compulsory. You need to take the programs. And the message that, first of all, they're so wedded to the NAAA approach in prison that it's mind-boggling. And the message is always, you can't quit this stuff on your own. You have to have NA. And I would tell them that the evidence doesn't support that claim. The evidence says no. And then, of course, the rebuttal is, well, you're just in denial. So I just wanted to pause for a second because I was so glad to hear you say that. Okay, continue. I'm sorry to interrupt. It's just something that really hits home for me.
I didn't know what was going on. Yeah, but you're right. That's the point. And I often have to tell parents that when they see their teenager, early 20s struggling, because there's a huge uptick in people experimenting, using substances in that time, and most of it resolves as life intervenes and you become more interested in other stuff. And so that is a key point, and that might be true for opiates as well as other substances. Opiates, we think, they're a little stickier than other substances. They're a little harder to quit on your own or to quit without psychosocial or treatment or medications. And so we've seen the best evidence with people getting medications to help exit it. Those are methadone, you mentioned, or buprenorphine or Suboxone, or there's an opiate blocker called naltrexone or Vivitrol. And so the evidence points to being on them can help people exit opiates in a safe way. They're certainly not for everyone. Some people, can get it in other, exit it and do better in other ways. But those are the main medications we're using. We also have increasingly medications that can help people drink less, help people get off nicotine. And so there are efforts to just sort of not, it can exist alongside 12-step models, AA, NA, but we're a big fan of having other psychological treatments, of using medications, of whatever it takes to get people to where they want to go. And then we're also, the ideal way to approach an individual is to offer them the menu of options and see what aligns with their goals and values. And so, we're not forcing, in an ideal world, any of this on anyone. Like, I think there's a lot of idea that we can force people to rehab, force people to meds, and that'll make it better, but we know it doesn't. And so I think the best approach is one that comes with, kindness, presenting people the evidence and options and saying, hey, here are some options that work. What makes sense with your values and what you want to get in life, and let's tackle that together. And if it doesn't work, we switch it up and can consider other things. And so that's hopefully the spirit. Sometimes people say there's only one way out, and it's through AA, or it's through medications, or it's through this rehab, or it's imprisoning folks. And anytime I hear that one way, I know one, it's not true, and two, it's going to push people away and not give them hope and not find something that works for them.
Now, as far as counseling or psychological treatments, which, like you said, by no means preclude medical treatments or medications, but from what I've read, I'm sure you know far more about this than I do, but the cognitive behavioral treatments are the most effective in treating not only these disorders, but a variety of disorders. Is that true? And if so, what are these approaches? What is a cognitive behavioral approach?
So cognitive behavioral therapy, and that's often given alongside dialectical behavioral therapy. They're two therapies that are therapist-led, that help you think about the thoughts, behaviors, feelings that are impacting your mood, anxiety, and substance use. And basically a therapist works with you to sort of better understand yourself, develop coping skills, understand the way your thoughts lead to anxiety or use, and to guide you in the right direction. And while historically rehabs, outpatient and inpatient, have been 12-step informed, which is, peer-based, you work the steps, you get the sponsor. Nowadays, they often offer a menu of options, which include 12-step, include CBT, DBT groups, include mindfulness and other interventions. And so, similar, some people really benefit from 12-step work. They just know in the meeting they found their people, and they can, work the steps, get the sponsor, and it sustains them. But for a lot of people, they go in there and like, no thanks. And so they don't like the ideas of a higher power or powerlessness or any of that. And so, and often they have co-occurring psychiatric stuff that responds better, we think, to CBT or DBT, these therapist-led therapies. And they can be individual, they can take place in a group setting. And so, they can be really helpful and often are first-line treatments.
Is it best? Well, first of all, is it accurate? Secondly, is it helpful to conceptualize addictions as diseases?
Yeah, it's a big debate. And the yes and no. I think there's so many factors that go into substance use. One of them is what happens to the brain when you're using. And we also know that certain people are more genetically predisposed to addiction. Like some people, when they use substances, something lights up in their brain because of their genetics that doesn't light up in the brains of other folks, and makes change very hard. And so, you can call that a disease or just sort of a risk factor because of your neurocircuitry. But there's so many other factors that go into substance use, which include your environment, trauma, early exposure to substances, and
Choice.
choice.
Has
Yeah,
to play a
no,
part as well, right?
choice is not in there. Choice is in there. You
Yeah.
can't ignore choice as part of it. It's sort of all true, and that's a little hard sometimes to wrap one's mind around, that all is true, that things just, it's sort of a perfect storm that leads to it, to getting stuck on a substance. It's not just one choice, it's not just one neurocircuitry or brain disease, it's not one family member, but things just sort of conspire in what we call sort of almost like a multi-hit hypothesis, we say these days. You can't say, it's just this or that, but the perfect storm. And that's, by the way, true for a lot of things. Like that's true for diabetes or high blood pressure. It's often a lot of things that conspire. It's been your diet over the years. It's
Well,
been
really, any human
genetics.
behavior, right?
Exactly. Yeah. So it's not, doesn't make it a different thing that we need to treat differently, because it's not totally all brain disease or a disease model, that even though it doesn't quite capture all of it, that's actually true for so many other things and in human behaviors and mental health issues and why we do anything. So it's so hard though to have nuanced discussions. Like but it's easiest when people are struggling because they're like, all right, I have some choice, but I can feel myself really compelled. I've got to think about all the people in my life that are using, and yes, I know this trauma impacted it, and that's often people's experience. It's not just one thing, and it rings more true when they can think about all the different factors.
I've, for decades now, in prison and out, argued against the disease model. And I'll tell you why. And I want to just get your take on it.
Yeah.
First of all, alcoholism was initially conceptualized as a disease by, I think his name was HM, and it's either Jelinek or Helenek. I don't know how to pronounce it, but it's Jell.
Uh-huh.
And he said alcoholism is disease when a person is addicted to alcohol and goes through delirious tremens, DTs, right? And outside of that, the person doesn't have the disease. But since then, concept creep, where more and more addictions get counted as disease. Now, alcoholism is a disease. I don't know about in a medical community. I'm just talking about in common parlance and in my addiction programs in prison. Alcoholism is a disease just if you have a problem with alcohol, and then it moves on to drug addiction and even to food addiction, internet addiction. So that's one problem I have with it, is the sort of concept creep where everything ends up being medicalized. Secondly, I don't know how you would ever test for such a thing outside of watching somebody's behavior. Like, you can't look at somebody or run a physical test and say this person has the disease of addiction. But my main issue with it is this: addicts often look for excuses. When you tell an addict that he has or she has a disease, oftentimes it becomes an excuse to not get help. The intent might be to destigmatize addiction, but it goes to the other extreme now. I'll never forget sitting in an NA meeting, and a guy said, when my aunt who has cancer relapses, nobody gets upset with her. Everybody loves her and supports her. But when I relapse, people get mad at me. And obviously, to me, the difference is in the choice element. As hard as the choice might be when you're under the compulsion to use, it's still a choice. Whereas the cancer patient, their cells are multiplying, they're getting sick. There's no choice in the matter. And if we're going to respect free choice to the point where we're not going to stigmatize addiction, I think we should respect free choice when somebody actually makes the choice to use. And saying it's a disease, I feel, robs them of that choice. What do you think about what I've just said? Does it make sense to you?
No, I get it. And the I think it's tricky. Like I have a hard time. There's just so many ways that people can get into trouble with substances, and there's so many different ways that someone can look at who's struggling with a substance use disorder, or they're using in a way that they can't stop, or it's impairing their function. And I think for each individual, there's like a different percentage, one that we can't measure, that's informed by so many different factors. And I do worry, like you say, that just using the disease model and sort of ignoring all these other things, we miss so much of what caused, the substance use disorder, and we miss a lot of what will make it better. Making the right decisions, surrounding yourself with the right people, and so there has to be more nuance, appreciation that there's so many different factors, as you're saying. And if you are in too much of one camp, similar to what we were talking about earlier with co-occurring disorders or other things, if you bank it all on one theory or one, then you're missing a whole lot of other ways that you can improve or understand yourself. And so I think just having all these different models in mind does give someone the best chance to sort of understand themselves and to make the way forward.
Okay. How optimistic are you going forward about everything we've talked about? Maybe decriminalizing drugs, getting rid of the stigma, treatments, lessening use. Is there cause for optimism, or is this just hopeless?
I'm always hopeful. I think we're inching forward. I mean, there's a lot of moments that could cause any of us to lose hope. The latest statistics, or the lack of policy movement forward, or sort of the lack of diversity of treatments and the way we think about it. But slowly but surely, we're talking more about it. We're getting more treatments in the mix. We're approaching things from different perspectives, harm reduction, and everything else. But it's going to be slow. I'm hopeful, but I recognize that we're at a very glacial pace here, and things aren't as quick as we would like. But I sort of lean, like, there are a couple of groups of people I never thought I would interact with as an addiction psychiatrist. One are family members whose loved ones struggle with addiction, and for the 23 million people that struggle, I realized, wow, the toll it takes on families and is really tremendous. And I've met with so many over the years who've lost a loved one or struggled, and sort of understood them a bit better. The other group that I didn't imagine getting to know so well, but are the people on the other side in recovery. And that's like 24 million strong. There's more people in recovery in the United States than with active substance use. So people really do get better. And sometimes for the way the news presents things, or the way we talk about addiction, it sounds like no one ever gets better, that either you're dying or your life sucks. But in fact, many people do get better and go on to live the lives that they want to live. And sometimes without treatment, sometimes with treatment. And so those people give me hope, and my hope is that we can make it easier for more and more people that are struggling to join that group as time goes on.
All right, before I let you go, is there anything we left out, anything you think needs to be said?
I think we covered it well. I think the thing that I always just like to remind people is that if they are struggling with substances, there's a tendency to hide it and not involve the people in your life or your clinical providers. And addiction really hides in the secrets. And so if you're struggling, I would say talk about it, get help. And even families that they're not sure it's impacting them, we actually recommend they start talking to kids about addiction and mental health at age 8 and 9. So, just keep talking about it. Listen to podcasts like this, familiarize yourself with the important facts. And, I think that's one of the best ways we can get out of this.
All right. Is there any place that people can find you? Do you have a website, a blog, anything out there?
Yeah, you can go to Weill Cornell's website. We have a substance use disorder and stigma. Let me look at the website, substanceusstigma.weill.cornell.edu. If you want to see.
Weill, can you spell that? Because it's got
I
a.
know I can't even say it. I don't know it's substanceusstigma.weill.cornell.edu.
All right. Dr. Avery, thank you for what you do, and thank you very much for joining us today. For now, this is the Rational Egoist. I'm Michael Liebowitz signing out. Remember, like, share, comment, subscribe. Till next time.